All right, now let's shift our focus to the heart's conduction system. So the conduction system is going to initiate and conduct the electrical events of the heart to ensure that the chambers of the heart contract at the correct time. It's composed of these specialized cardiomyocytes, or cardiac muscle cells, that have lost the ability to contract, but they can still propagate action potentials. The activity of the heart's conduction system is going to be influenced by the autonomic nervous system. So that's going to be your sympathetic and parasympathetic nervous systems. All right, so what are the parts of the conduction system? Well, it starts at the sinoatrial node, or the SA node. This guy initiates the heartbeat, so it is the heart's natural pacemaker. It's located high up in the posterior wall of the right atrium. Then you've got the atrioventricular node, or the AV node. This is located in the floor of the right atrium, near the right AV valve. So the impulse goes from the SA node to the AV node, then to the AV bundle. This is also called the bundle of His. This extends from the AV node through that interventricular septum. Remember that septum between the right and the left ventricles. And it's going to divide into left and right bundles. You might sometimes hear these referred to as the left bundle branch and the right bundle branch. Then the signal propagates through the subendocardial branches. These are often known as the Purkinje fibers. And these guys extend from the left and right bundle branches at the heart's apex, and then they move superiorly through the walls of the ventricles. Okay, so here it is laid out for you on the heart. So here's the sinoatrial node, the SA node here, the pacemaker. This is going to initiate the signal, and this signal is going to spread throughout the atria. And that signal is going to not be able to spread to the ventricles because, remember, we have that fibrous skeleton of the heart here blocking that signal. So the signal is going to spread through the atria, and then the only way it's going to be able to get out is when it reaches the AV node. From the AV node, it's going to move through the AV bundle, or the bundle of His. It's going to separate into the right branch and the left branch. And then it's going to propagate to the Purkinje fibers. And the Purkinje fibers are kind of down here at the apex of the heart, and then they course more superiorly through the heart. And so the signal, the contraction kind of starts at the apex of the ventricles and works upwards. And that's how the ventricles have kind of a ringing motion, like ringing a mop. How is the heart innervated? Well, there's this place called the cardiovascular center within the medulla oblongata of the brain, and within that there's a cardiac center that's in charge of heart rate. So the cardiac center is going to receive signals from baroreceptors and chemoreceptors located in the cardiovascular system, and it's going to send signals to the heart via sympathetic and parasympathetic pathways. Remember, the sympathetic innervation is going to increase heart rate. Parasympathetic innervation is going to decrease heart rate. Now, I want to point out that this is a modification of cardiac activity. The innervation of the heart does not initiate cardiac activity, okay? Remember, the heart beats on its own. What the sympathetic and parasympathetic pathways do is they influence the rate and the force of the heart's contractions. Okay, so you've got parasympathetic motor neurons that are going to extend from the cardioinhibitory center of the cardiac center. These guys are relayed via that vagus nerve. Remember, cranial nerve 10. And there's a pair of vagus nerves. So there's a right vagus nerve and a left vagus nerve. And the right vagus innervates the SA node, while the left vagus innervates the AV node. And stimulation, parasympathetic stimulation, is going to decrease heart rate. Then you've got sympathetic motor neurons that extend from the cardioacceleratory center of that cardiac center. The sympathetic pathway is relayed via neurons from the T1 through T5 segments of the spinal cord. Sympathetic neurons are going to extend to the SA node, the AV node, the myocardium, as well as the coronary arteries. And there, they're going to increase coronary artery dilation. And it's going to stimulate the increase of heart rate as well as increased force of contraction. All right, and here it is laid out in a diagram for you. So here's the cardiac center of the medulla oblongata. You have the cardioacceleratory center and the cardioinhibitory center. The cardioacceleratory center has neurons, sympathetic neurons, that are going to synapse at the T1 through T5 segments, and then innervate throughout the heart, the SA node, the AV node, the myocardium, and the coronary arteries. Here's the cardioinhibitory center, and again, it's going to be that vagus nerve that extends down. So you've got the right vagus nerve here that's going to innervate the SA node, and the left vagus nerve here that's going to innervate the AV node. And remember, sympathetic innervation is going to speed the heart up, and it's going to make more forceful contractions. Parasympathetic innervation is going to slow heart rate down. Okay, so how does the heart contract? Well, it's going to involve two events. First, you need the conduction system to initiate and move that signal throughout the heart. Then you need the cardiac muscle cells to respond to that signal. And they're going to respond to that signal by initiating action potentials and contracting. Okay, so here we're looking at a nodal cell from the SA node. And so the SA nodal cell is going to initiate the action potential. And then that action potential is going to spread throughout the conduction system until it reaches the ventricles. Now, what happens when that action potential reaches cardiac muscle cells? Well, that action potential is going to be propagated along the sarcolemma, or the cell membrane of that cardiac muscle cell, and that's going to cause those thin filaments to slide past those thick filaments and the sarcomere to shorten, and that is muscle contraction. Okay, let's talk a little bit more about those SA nodal cells. Remember, these are the guys that initiate the heartbeat. They have a resting membrane potential of about negative 60 millivolts, but this resting membrane potential is not stable. They have this quality called the pacemaker potential. This is the ability of those cells to reach threshold without any outward stimulation. And I'll tell you how they do that here in a second. SA nodal cells are going to have several different membrane proteins. So they have sodium-potassium pumps, they have calcium pumps, they have leak channels, and then they have specific voltage-gated channels as well. They have slow voltage-gated sodium channels, fast voltage-gated calcium channels, as well as voltage-gated potassium channels. Okay, SA nodal cells exhibit this thing called autorhythmicity, and that is spontaneous firing of the cells. So how do they reach threshold on their own? Well, remember, resting membrane potential is at about negative 60 millivolts. And at about negative 60 millivolts, slow voltage-gated sodium channels are going to open. And this is going to allow sodium to flow into the cell. Now you've got positive ions coming inside of the cell. That's going to increase the membrane potential, make it more positive. So it goes from negative 60 millivolts to negative 40 millivolts. And that is the threshold. At threshold, you're going to get depolarization. What happens is at negative 40 millivolts, those fast voltage-gated calcium channels open, and this allows calcium to flow in. So now we've got more positive ions flowing in. And you'll notice calcium has a positive 2 charge. So the membrane potential is going to change rapidly from negative 40 millivolts to just above 0 millivolts. Then at 0 millivolts, you're going to get repolarization. So this is where that resting membrane potential, that membrane potential is going to become more negative. So what happens at 0 millivolts, those calcium channels close, so calcium stops flowing in, and voltage-gated potassium channels open, allowing potassium to flow out. So now you're losing positive ions. So the membrane potential is going to become more negative, and it eventually settles back down to about negative 60 millivolts, the resting membrane potential. Now remember, at negative 60 millivolts, those slow voltage-gated sodium channels are going to open, allowing sodium to flow in, and then the whole process is going to begin again. Okay, at rest, one SA node action potential starts about 0.8 seconds after the last. So this is going to equate to about 75 heartbeats per minute. However, if you were to take SA nodal cells and grow them in culture and watch them beat, they would fire faster. They would fire at about 100 beats per minute. However, in the body, remember, we have vagal tone. This is that parasympathetic innervation that's kind of always on. And so this dampens down our resting heart rate and makes it a little bit slower. All right, this is just showing that pacemaker potential. So here we have the voltage-gated sodium channel. It's going to open at negative 60 millivolts and allow sodium to flow in. Threshold is going to be reached at negative 40 millivolts. That's going to trigger depolarization. And you'll see the sodium channels close, but the voltage-gated calcium channels open. So now calcium's coming in. And now we're going to get just above 0 millivolts for our membrane potential. At about 0 millivolts, we're going to switch into repolarization. So those calcium channels close, those sodium channels remain closed, and now we have a voltage-gated potassium channel that opens. And this is going to allow potassium to exit the cell, making the inside of this membrane more negative than it was before. You can see this represented graphically down here. So slope number 1, this is the leakage inwards of sodium through those voltage-gated sodium channels. Then you get depolarization. That's this slope here, number 2. And remember, this is where calcium flows in. And calcium has a positive 2 charge, so you're going to see depolarization happen very quickly. Then when we get just above 0 millivolts, we're going to hit repolarization. So you can see now potassium is moving outwards. Those calcium channels have closed. And so we're losing positive ions. So the membrane is becoming more negative until it comes all the way down here to negative 60 millivolts. And then those sodium channels open again, allowing sodium in. And you reach threshold, you depolarize, you repolarize, and it starts all over again. Okay, spread of the action potential. So after starting at the SA node, the action potential is going to spread down through the rest of the heart. The action potential first is distributed through those atria, like I mentioned. And how is that action potential spreading from one muscle cell to the next muscle cell? Well, remember, these cardiac muscle cells have those things called gap junctions, which are essentially just ion channels that allow the free flow of ions from one cardiac cell to the next. So the excitation can travel rapidly among the cardiomyocytes, and they can contract essentially as one unit. Once the action potential is distributed through the atria, it's going to reach that AV node. Now at the AV node, the action potential gets delayed a little bit. And the reason for this is because those AV nodal cells are smaller in diameter and they have fewer gap junctions than the rest of the conducting system. Remember that there is that fibrous skeleton in the heart that separates the atria from the ventricles, that blocks almost all of the conduction through the heart except for the AV node. So the AV node is kind of a site of a bottleneck. That is, it's the only pathway through. And so it's made up of smaller cells with fewer gap junctions. When the signal gets there, it's going to be delayed. And that delay gives the ventricles time to fill up with blood before they contract. So that delay at the AV node is critical. Okay, then the action potential passes through the AV node, through the AV bundle, right, the bundle of His, down the right and left bundle branches to those Purkinje fibers. And then the action potential is going to spread from the Purkinje fibers throughout the ventricles. And remember, those gap junctions in the muscle cells are going to allow that impulse to spread throughout the ventricles so that they contract nearly simultaneously. Let's talk a little bit about the spread of the action potential through the ventricles. So remember, those Purkinje fibers supply the ventricles, and they're going to be relatively large in their diameter. This is going to allow for that action potential to spread down them extremely rapidly and ensure that the ventricles contract at the same time. Now, the papillary muscles, these guys, remember, they hold those heartstrings, the chordae tendineae, which tether the cusps of the AV valves so that they don't flow backwards when the ventricles contract. Those papillary muscles are stimulated to contract just a little bit before the rest of the ventricles. So they start to pull on those cusps just prior to increase in pressure inside of the ventricles. And remember, contraction of the ventricles is going to begin at the apex and work its way superiorly. And this kind of squeezes blood out of those ventricles up towards those major arteries, the pulmonary trunk and the aorta. Okay, let's talk a little bit about an ectopic pacemaker. So what is an ectopic pacemaker? Well, ectopic just means something is someplace where it's not supposed to be. So an ectopic pacemaker is a pacemaker somewhere other than the SA node. Now, something you need to know about the conduction system cells, the ones other than the SA node, is that they also have the ability to spontaneously depolarize, but they depolarize at slower rates than the SA node. So if you lose function of your SA node, your backup pacemaker is going to be the AV node. Now the AV node spontaneously depolarizes, but at a rate of only 40 to 50 beats per minute. This is fast enough to sustain life. And if you see a patient come in and their EKG is not showing P waves, right, so their atria are not depolarizing, but their heart rate is about 40 to 50 beats per minute, you're going to be thinking, hey, this is a rhythm originating at the AV node. This is also called a junctional rhythm. Now, what happens if you lose function of the SA node and the AV node? Well, cardiac muscle in the ventricles can spontaneously depolarize. And this time only 20 to 40 beats per minute. Usually this is too slow to sustain life. So in patients who have an issue with their pacemaker, one option for treatment is a mechanical pacemaker. And this can be implanted, and it basically fires electrical impulses at a specified rate in order to stimulate the heart to contract. Okay, we talked about the SA nodal cells at rest, and we talked about what the depolarization of those look like on a graph. Now let's talk about cardiac muscle cells at rest, and then we're going to go into how they depolarize and what it looks like when represented graphically. So cardiac muscle cells, they're going to contain sodium, potassium pumps, calcium pumps, and leakage channels as well. And their resting membrane potential is about negative 90 millivolts. They contain these specific voltage-gated channels. They have fast voltage-gated sodium channels, slow voltage-gated calcium channels, and then voltage-gated potassium channels. And these guys are going to come into play when the action potential arrives. Now, when at rest, these voltage-gated channels are going to be closed. Okay, so what happens? Well, you get depolarization. This is going to occur when that impulse from the conduction system or through the gap junctions reaches the muscle cell, and that muscle cell is going to open fast voltage-gated sodium channels. So sodium is going to flow into the cell, making that membrane potential more positive. So it's going to go from negative 90 millivolts to positive 30 millivolts. Now at positive 30 millivolts, those voltage-gated sodium channels are going to start to close. Now, cardiac cells are unique in that after depolarization, they're going to enter a phase called plateau. And what happens here is that voltage-gated potassium and slow voltage-gated calcium channels open. And this allows potassium to leave the cardiac muscle cell at the same time that calcium is entering. So the resting membrane potential is going to slowly, very slowly, become a little bit more negative. However, the membrane is going to remain depolarized. Okay, eventually during that plateau phase, you're going to reach a certain membrane potential, and voltage-gated calcium channels are going to close while potassium channels remain open. And this is going to allow that membrane potential to drop back down to negative 90 millivolts. All right, here it is represented graphically for you. So the first segment here is depolarization. So remember, those fast voltage-gated sodium channels are going to open, and sodium is going to rapidly enter the cardiac muscle cell. This is depolarization. We go from about negative 90 millivolts to about positive 30 millivolts. And at positive 30 millivolts, those voltage-gated sodium channels close, and voltage-gated potassium channels open. Potassium is going to flow out of the cardiac muscle cell, and slow voltage-gated calcium channels are going to open. And this is going to allow calcium to flow into the cell. And so you can kind of see this flattened area of the curve here is the plateau, where you've got movement of both of these ions in and out of the cardiac muscle cell. Eventually you're going to get to a point where those voltage-gated calcium channels close. Now the voltage-gated potassium channels remain open. So now this is repolarization. You have no influx of ions. You just have efflux or outflow of potassium ions. So your membrane is going to become more negative. And it does so until it reaches that resting membrane potential of about negative millivolts. And then the cell is ready to be stimulated all over again and undergo this process once again. Now, calcium is also playing a role in the actual contraction of the muscle fibers. So calcium enters from outside the cell, but it also enters from the sarcoplasmic reticulum. Remember, that's that storage network of calcium inside of the muscle cell. And when this calcium enters the muscle cell, it's going to cause muscle contraction. And how it happens, remember, it's going to be like skeletal muscle. So calcium is going to bind to troponin. That's going to cause troponin to change its shape a little bit. And that change in shape is going to move the molecule tropomyosin out of the way. Remember, tropomyosin is normally blocking the myosin binding sites on the actin filaments. So when tropomyosin is moved out of the way, myosin can bind to actin. And that's when you get cross-bridge formation, you get the power stroke, you get the release of the myosin head, and then you get the reset of the myosin head, and the whole thing can start over again. Eventually, you are going to get a decrease in the calcium levels, and that's going to lead to relaxation of the cardiac muscle. So those calcium channels close, and the calcium pumps move it from the cytosol into either the sarcoplasmic reticulum or outside of the cell. Okay, one of the things that plateau phase does is it makes it impossible to excite that cardiac muscle cell during that plateau phase. And this gives the cell time to contract and then to relax. So unlike skeletal muscle, cardiac cells are going to have a long refractory period. The cell contracts and relaxes before it can be stimulated again, and so it makes sustained contraction impossible. So the heart cannot go into tetany. Okay, so here it is laid out for you in a skeletal muscle cell. So the blue line here is showing the action potential. The red line is showing the actual muscle contraction. And then this green region is the refractory period. So that's the period in which if that muscle cell receives another impulse, it cannot respond to that impulse. You can see that the refractory period here is very short. So you could potentially stimulate this muscle cell as soon as right here, and you would get another contraction. And you can see that over here, you see summation of the contractions until you get to tetany, where it's just a sustained muscle contraction. And this is in response to frequent stimulation. Contrast that with the cardiac muscle cells. So again, you've got the action potential laid out for you here on the blue line. Here's that plateau phase. You can see that plateau phase lends to a very long refractory period. So the muscle fully contracts and then it relaxes almost completely before it can be stimulated again. And this is vital for the function of the heart as a pump. If the cardiac cells could go into tetany, the heart would not be able to pump and you would die. So you need your muscle cells in the heart to be able to relax almost completely in order to allow the heart to fill with blood and in order to be able to pump blood out with the next contraction. All right, now let's talk a little bit about electrocardiograms. So the electrocardiogram, also called the ECG, or an older reference is the EKG. That's the German for it, electrocardiogram. The cardio in German starts with a K. This is just a set of skin electrodes that are put on the chest that detect electrical signals of the cardiac muscle. And this is a very common diagnostic tool, so I want you to get a little bit familiar with it. Your electrocardiogram has waves, and then it has segments. So the waves we'll talk about are the P wave, the QRS complex, and the T wave. The P wave, this is what happens during the electrical changes of atrial depolarization, originating in the SA node. So if you look at an EKG and it has P waves, you know that your patient's SA node is firing. The QRS complex, this is like three waves kind of put together. And what it is the electrical changes associated with the depolarization of the ventricles. So the P wave is what happens right before the atria contract, and the QRS complex is what happens right before the ventricles contract. Now, at the same time as the QRS complex, the atria are repolarizing, but we can't see that repolarization on the EKG because this QRS complex kind of takes up all the space. Then you have a T wave, and the T wave is the electrical change that's associated with those ventricles repolarizing. Okay, the segments I want you to be aware of. So these are between waves, and they correspond to the plateau phases of the cardiac action potential. So there's no electrical change occurring during these segments. There's the PQ segment. This is between the P wave and the QRS complex, and it's going to be associated with those atrial cells plateau. That is, the atria are contracting. Then you have the ST segment. This is between the QRS complex and the T wave. And this is associated with plateau of the ventricles. That is, the ventricles are contracting. And this is what they look like when they're represented graphically. So first you have your P wave, that's this little guy here. Then you're going to have your PQ segment here. This is, remember, where the atria are actually contracting. Then you're going to have your QRS complex. Okay, and this is the ventricles depolarizing. Then the ST segment is when the ventricles contract. And then the T wave is when those ventricles repolarize, and then the heart is ready to do it all again. Okay, so here we have the action potential of the cardiomyocytes superimposed on an EKG. So you can see here are the cardiomyocytes in the atria. Here's depolarization. It aligns with the P wave. Then you've got the plateau phase. This is while the atria contract. That aligns with the PQ segment. And then again, you're going to have depolarization. This is when the ventricles depolarize. You've got plateau. This is when the ventricles are contracting. And then repolarization. That's the T wave. Notice that you have repolarization of the atria here, but it doesn't really come through because the depolarization of the ventricles is so massive. So the only thing that we see recorded on the EKG is the depolarization of the ventricles. But the atria are repolarizing at this same time as well. Okay, and then you can have intervals. So there's the PR interval and the QT interval. The PR interval is the time from the beginning of the P wave to the beginning of the QRS deflection. And basically what this is showing is from atrial depolarization to ventricular depolarization. And this is the time that it takes to transmit that action potential from the SA node through the entire conduction system. So increases in your PR interval may indicate that you have a problem with your conduction system. And then there's the QT interval. This is the time from the beginning of the QRS to the end of the T wave. And this reflects the time of ventricular action potentials. So the entire time that the ventricles are depolarizing up through their repolarization. Length of the QT interval generally depends on heart rate. So in general, the faster the heart rate, the shorter the QT interval. Changes in the inherent length of that QT interval, either making it longer than it should be or shorter than it should be, can result in tachyarrhythmias. These are rapid, irregular heart rates that can deteriorate into fatal rhythms. There are some medications, some conditions that lengthen the QT interval, and some conditions that shorten the QT interval. And basically what this does is this messes with the contraction of the ventricles. It messes with the ventricles being able to fill up properly and fully contract all that blood out. And so messing with the QT interval can have devastating effects. All right, let's talk a little bit about cardiac arrhythmia. This is going to be any abnormality in the heart's electrical activity. So let's start off with heart blocks. What is heart block? Well, it's going to be some sort of impaired conduction of that signal through the heart. A heart block can result in lightheadedness, fainting, an irregular heartbeat, and palpitations. There's several different kinds of heart block. First degree heart block or first degree AV block. This is when that PR interval gets longer. So this is indicating that there's slow conduction between the atria and the ventricles. Second degree heart block. This is going to occur when some of the atrial impulses fail to reach the ventricles. And then you have third degree AV block. This is also known as complete heart block. And the reason for that is because the atria and the ventricles completely disassociate from one another. They stop being able to communicate. So none of the action potentials from the atria reach the ventricles. So the atria go on beating like normal at their normal rate, and the ventricles start beating at their backup rate, remember, which is about 20 to 40 beats per minute. So what you'll see is you'll see P waves on the EKG going at a rate of about what the SA node fires at, right, somewhere between about 60 and 100. And then you'll see QRS complexes that are going at a rate of about 20 to 40 beats per minute. Here's what they look like on EKG. So here's first degree AV block. And the definition of first degree AV block is going to be a PR interval greater than 200 milliseconds. And all you really need to know is that this PR interval is longer than it should be. And that's indicating that there's slow conduction of that impulse throughout the heart's conduction system. Next, there's second degree heart block, and there's two subtypes of second degree AV block. Don't worry about that. All I want to show you here is that you've got some signals from the atria, right, these P waves that are being transmitted, and you get a QRS complex after the P wave like you should. Here you get a QRS complex after the P wave like you should. Here you get a QRS complex after the P wave like you should. Here you have a P wave and no QRS complex. So the signal got dropped. You see that down here in the type 2 second degree AV block as well. You have a P wave here that does not transmit its signal to the QRS complex. So the atria are not communicating with the ventricles consistently. And finally, you have third degree or complete heart block. And what I want to show you here is look at the P waves. So here's a P wave, here's a P wave, here's a P wave, here's a P wave. Look at how regular they are, how regularly spaced they are. And notice there's not any QRS complexes after these P waves. Here is a QRS complex, and here is a QRS complex, and these guys are beating on their own. So here you have the QRS, the ventricles, beating at a much slower rate. There's a lot more time in between this beat and this beat than there is between the P waves. The P waves, the atria, are beating much faster, and so you can tell that the atria and the ventricles have become uncoupled here. Okay, and then there are premature ventricular contractions. What happens here is the ventricles contract prematurely before they should. These result from stress, stimulants, or sleep deprivation. And what happens is there's an abnormal action potential that occurs either within the AV node or the ventricles themselves that sets the ventricles to contract earlier than they should. Now, these happen occasionally, normally, in healthy people, and so they're not detrimental unless they occur in large numbers. And then when they occur in large numbers, you're going to have trouble with your ventricles pumping enough blood out because they're not relaxing like they should. They're not filling up fully with blood. Then there's atrial fibrillation. This is going to be uncoordinated contraction of the atria, okay? Chaotic timing of those atrial action potentials. And then finally, there's ventricular fibrillation. This is uncoordinated contraction of ventricles. This results in pump failure. It's going to lead to the death of heart cells, and it is ultimately a fatal condition unless intervened upon. And how you treat ventricular fibrillation is either with a manual defibrillator or, if you have access to one, an automated external defibrillator or an AED. Okay, so this is what atrial fibrillation looks like, this tracing up here on the top. And what I want to show you here is just these crazy wiggly lines. This EKG does not look nice and clean like it should. It has all these wiggles here, and these wiggles are atrial contractions. So the atria are kind of quivering, and those quivers are sending signals, and the EKG picks it up and copies it down as kind of these squiggly lines. Down here is ventricular fibrillation. This is important to be able to recognize. If you ever see this in a patient, if you see this happen in a patient, immediate action is required. Hit the code blue button, call for backup, okay? This requires immediate intervention. Okay, now let's move into the cardiac cycle. So what is the cardiac cycle? Well, it's going to be all the events that are occurring in the heart from the start of one heartbeat until the start of the next heartbeat. This is going to include contraction, which we call systole, and relaxation, which we call diastole. Now, contraction is going to increase the pressure inside of the heart. Relaxation decreases the pressure inside of the heart. What do you need to know? You need to know that blood moves down its pressure gradient. That means it's going to move from areas of high pressure to areas of low pressure. And remember that there are valves inside the heart that ensure that the flow moves forward, that it does not backflow into the chamber that it just came out of. Okay, what is the most important driving force to the blood flow here? It's going to be ventricular contraction. So when the ventricles contract, that's going to raise pressure inside of the ventricles. That's going to close those AV valves, push them closed, and it's going to push on those semilunar valves until they open and blood gets ejected to the artery. Ventricular relaxation, on the other hand, is going to lower the pressure inside of the ventricles. That's going to close those semilunar valves, and it's going to open those AV valves. And so you've got blood from those upper chambers being drawn down into that lower pressure area in the ventricles. Okay, so what's happening at the very beginning of the cardiac cycle? Well, all the chambers are at rest, blood is returning to those atria, and then the blood is passively moving from the atria into the ventricles. So those AV valves are open, and the pressure in the atria is higher than the pressure in the ventricles. So blood moves from the atria down to the ventricles. At the beginning of the cardiac cycle, the semilunar valves are closed, and this is because the blood in the arteries, in the pulmonary artery and in the aorta, the pressure in those arteries is higher than the pressure in the ventricles. All right, so what are the actual events of the cardiac cycle? Well, you start with atrial relaxation and ventricular filling. So we said all heart chambers are relaxed. Atrial blood pressure is going to force those AV valves open. Blood is going to passively flow into the ventricles. And remember, those semilunar valves remain closed. Next, you're going to go into atrial contraction and ventricular filling. So the SA node starts an atrial excitation. The atria then contract, and this is going to push what blood remains in them into the ventricles. The ventricles get filled to their end diastolic volume. This is really important. The end diastolic volume is essentially the amount of blood that's in the ventricles after relaxation. It's the amount of blood that the ventricles have to work with to try to push forward into the pulmonary circuit or the systemic circuit. The atria, after contracting, are going to relax and remain relaxed for the remainder of the cardiac cycle. Next, you have isovolumic contraction. So what happens is the Purkinje fibers initiate ventricular excitation and the ventricles contract. The pressure inside of them rises and those AV valves are pushed closed. However, at this point, ventricular pressure is still less than the pressure in those big arteries in the pulmonary trunk and the aorta. So the semilunar valves remain closed. And the way you can remember this is that this is isovolumic. So same volume. So all the valves are closed. There's really no change in the volume of the heart at this point. The ventricles are contracting, but the volume of blood in the heart remains the same. Then you enter ventricular ejection. So the ventricles are continuing to contract, And now that pressure inside of the ventricles has increased to the point that it rises above the pressure in the pulmonary trunk and the aorta. So those semilunar valves are forced open and blood is ejected into the arteries. Let's take a moment here and talk about a couple of volumes that you need to know. You have the stroke volume. So this is the amount of blood that's actually ejected by the ventricle. And then you have the end systolic volume. So the ventricle cannot eject all of the blood. So there's always a little bit of blood remaining after the end of systole. This is what's called the end systolic volume. Now, how do you calculate the end systolic volume? Well, it's going to be the end diastolic volume, right? The volume after the ventricles are done filling, minus whatever the ventricles ejected, that is the stroke volume. So end diastolic volume minus stroke volume will get you end systolic volume. Next, you enter a period of isovolumic relaxation. Here the ventricles relax and they start to expand, and this is going to lower pressure inside of those ventricles. Atrial pressure is then going to be greater than ventricular pressure. Blood is going to slide back toward the ventricles in those arteries, because now the pressure in those arteries, the pulmonary trunk and the aorta, is higher than the pressure inside those ventricles. So remember, blood moves from areas of high pressure to low pressure, so blood is going to be drawn from those arteries back toward the ventricles, but those semilunar valves are there to stop blood from backflowing into the ventricles, so they slam shut. At this point, the AV valves remain closed. So remember, during isovolumic contraction and isovolumic relaxation, all the valves are going to be closed. So blood neither enters or leaves, and that's why it's called isovolumic. Okay, here are the events of the cardiac cycle represented graphically. So we start with atrial relaxation and ventricular filling. So remember, the atria are relaxed here, and blood is just kind of passively dropping into the ventricles. The AV valves are open, the semilunar valves are closed. Then the atria are going to contract, and we're going to enter atrial contraction and ventricular filling. So the atria contract and empty out what's remaining in them into the ventricles. Then you're going to enter the phase of isovolumic contraction. So the ventricles start to contract. This pushes blood upwards and forces those AV valves closed. Remember, though, the pressure inside of the ventricles at this point is still lower than the pressure inside of the arteries. So the blood up here in the pulmonary trunk and the blood in the aorta is drawn down towards the ventricles, but the semilunar valves are there to keep it from backflowing. So the semilunar valves are still closed at this point. Next, you're going to get ventricular ejection. So the ventricles continue to contract, and now the pressure inside of the ventricles has risen to where it's higher than the pressure inside of these big arteries. So blood is ejected, pushes open those semilunar valves, and is ejected out through the pulmonary trunk and the aorta. Finally, you're going to come to isovolumic relaxation. What happens here is the ventricles relax, and when they do that, pressure inside of the ventricles drops, and it becomes lower than pressure inside of those arteries. So the blood inside those arteries are drawn back towards the ventricles, but the semilunar valves snap shut and prevent backflow. Pressure is still higher in the ventricles than in the atria, so the AV valves are still closed at this point for just a moment. Now I want to show you an animation that goes over what we just talked about.
Ventricular contraction causes the atrioventricular valves to close, which signals the beginning of ventricular systole. The semilunar valves were closed during the previous diastole and remain closed during this period. Continued ventricular contraction increases pressure in the ventricles above the pressure in the aorta and pulmonary trunk, causing the semilunar valves to open. When the ventricles relax and their pressures drop, blood flowing back toward the relaxed ventricles causes the semilunar valves to close, which is the beginning of ventricular diastole. Note that the atrioventricular valves remain closed. When the pressure in the ventricles becomes lower than the pressure in the atrioventricular valves open and blood flows into the relaxed ventricles. This accounts for most of the ventricular filling. The atria then contract and complete the ventricular filling.
Okay, the balance between the ventricles. So, equal amounts of blood are going to be pumped by the left and the right ventricles. The left ventricle is going to pump blood farther, so it has to be stronger than the right ventricle. Remember, the right ventricle only pumps to the pulmonary circuit, and the pulmonary circuit is very short. However, the ejected blood volumes must be the same, or edema can occur. For example, if the left ventricle is pumping out less blood than the right ventricle, you can see how blood can kind of get backed up in that pulmonary circuit, and that can cause pulmonary edema. Okay, and this brings us to cardiac output. Cardiac output is very important. You got to know this. So this is the amount of blood that's pumped by a single ventricle in 1 minute, and it's measured in liters per minute. What it is it's the measure of the effectiveness of the cardiovascular system, and it's going to increase in healthy individuals during exercise. So during exercise, normally your cardiac output will increase because you need more oxygen. You need more blood to get to your muscles. Your muscles are using more oxygen. So you need to increase the output of blood, and that's increasing cardiac output. Cardiac output is determined by the heart rate in beats per minute and the stroke volume, which remember is the amount of blood that's ejected per heartbeat. So here's your formula: heart rate times stroke volume equals cardiac output. And you just plug the numbers in. So 75 beats per minute times 70 milliliters per beat comes to 5.25 liters per minute. Okay, how do we maintain cardiac output at rest? Well, remember, cardiac output has to meet the needs of the tissues. So individuals who have smaller hearts are going to have smaller stroke volumes. So to maintain their cardiac output, they're going to need an increase in heart rate. Examples here would be women and children. Individuals with stronger hearts are going to have larger stroke volumes, so they can get by with slower heart rates. Athletes are a big example here. Endurance athletes have thicker heart walls and therefore stronger hearts. Just as an example, Michael Phelps, the Olympic swimmer, his resting heart rate at the peak of his career was somewhere around 38 beats per minute. The normal for the average non-athlete human is between 60 and 100. Okay, cardiac reserve. Cardiac reserve is the capacity to increase cardiac output above the cardiac output you have at rest. So what you do is you subtract cardiac output at rest from the cardiac output with exercise. Heart rate accelerates and stroke volume increases during exercise, and this is why your cardiac output increases during exercise. What cardiac reserve does is it gives a measure of the level of exercise an individual can withstand. So, for example, the cardiac output of a normal, healthy, non-athlete, it can increase about 4-fold, and it can increase up to about 7 times in athletes. All right, now let's talk about factors that influence heart rate. Chronotropic agents are what we call agents that are able to change the heart rate. What they do is they alter the activity of nodal cells, either the SA node and or the AV node. Often they're going to work via the autonomic nervous system or through hormones. There are positive chronotropic agents and there are negative chronotropic agents. Positive chronotropic agents increase the heart rate. Negative chronotropic agents decrease heart rate. So for positive chronotropic agents, we have, first and foremost, sympathetic system, okay? The sympathetic nerve stimulation. What this is going to do is it's going to cause norepinephrine to be released onto the heart, and it's also going to cause the adrenal glands to release epinephrine and norepinephrine as well, which circulate and make their way to the heart. There, norepinephrine and epinephrine bind to nodal cells and increase their firing rate. And they do this by binding to beta-1 adrenergic receptors on those cells. These beta-1 adrenergic receptors are cell surface receptors, and so they're going to interact with a G protein, and they're going to go through the adenylate cyclase, cAMP, and protein kinase signaling cascade. And at the very end of that signaling cascade, what ends up happening is a bunch of calcium channels get phosphorylated. And that phosphorylation enhances calcium influx into the cell so that the cell fires sooner. Thyroid hormone is also a positive chronotropic agent. And the way it works is it increases the number of those beta-1 adrenergic receptors on the nodal cells. Some other substances can act on that signal transduction pathway to increase heart rate. So, for example, nicotine. Nicotine increases the release of norepinephrine, and norepinephrine then stimulates the heart. Cocaine. Cocaine is a norepinephrine reuptake inhibitor. So more norepinephrine hangs around in the synapse, so it can act on the heart for a longer period of time. And then caffeine. Caffeine actually inhibits the breakdown of cAMP. So again, there's more cAMP hanging around to do its job, and you get more phosphorylation of those calcium channels. All right, and this is just kind of showing you what we talked about with the positive chronotropic agents. So here's your SA nodal cell. Here's the cell membrane, and you'll see it has a beta-1 adrenergic receptor in it. Here is an axon of the sympathetic neuron. Here's the synaptic knob. Here it is releasing norepinephrine into the synapse, and norepinephrine is then going to bind to the beta-1 adrenergic receptor, which is going to activate the G protein, which is going to activate adenylate cyclase, which is going to cause the production of cAMP, which is going to cause protein kinase to be activated, which is going to cause a lot of phosphorylation, and ultimately calcium channels open, and more calcium can come into the cell, so the cell can fire sooner. Note up here, we have the adrenal medulla. Remember, this guy releases epinephrine and norepinephrine upon sympathetic stimulation. So we also have epi and norepi traveling in the bloodstream that's going to reach our SA nodal cells as well. Here is nicotine. It's going to increase the release of norepinephrine, so it acts right here. Cocaine inhibits norepinephrine reuptake, so it acts at the level of the synapse. And then caffeine works within the SA nodal cell itself to inhibit breakdown of cAMP. Okay, negative chronotropic agents, we said, decrease heart rate. A very important negative chronotropic agent is going to be the parasympathetic nervous system. So instead of releasing norepinephrine, parasympathetic neurons release acetylcholine onto those nodal cells. Acetylcholine then binds these receptors called muscarinic receptors, and all these are potassium channels. When acetylcholine binds to them, they open, and this allows potassium to exit the cell, making the cell more negative. Okay, so that means it's going to take a longer time for that cell to reach its threshold voltage, so the heart rate slows. Beta blockers are also negative chronotropic agents. They are so named because they inhibit or block the beta-1 adrenergic receptors. And this is going to interfere with the action of epinephrine and norepinephrine on the heart, slowing the heart rate down. We use beta blockers for a variety of conditions, chiefly high blood pressure and some types of arrhythmia. All right, and other things that influence the heart rate include autonomic reflexes. So we have baroreceptors and chemoreceptors throughout the cardiovascular system, and they send signals to that cardiac center of the medulla oblongata. The cardiac center then influences the sympathetic and parasympathetic systems to alter the cardiac output as needed. There's also the atrial reflex. This is also called the Bainbridge reflex. What this does is it protects the heart from overfilling. So there's baroreceptors in the atria, and they're going to be stimulated by increased venous return. What does that mean? Well, that means that more blood is returning to the heart, and so the atria are stretching. And when they stretch, those baroreceptors are stimulated, and this increases nerve signals to the cardioacceleratory center. This excites sympathetic neurons, and the sympathetic neurons excite the heart. The heart rate then increases, and this helps move blood through the system more quickly so that there's less atrial stretch. Okay, variables that influence stroke volume. So remember, stroke volume is the amount of blood that the heart ejects in one beat. This is going to depend on the end diastolic volume. Typical end diastolic volume is 130 milliliters, and the end systolic volume, which typically is around 60 milliliters. If you take the end systolic volume and you subtract it from the end diastolic volume, you get the stroke volume. So for a typical resting adult, stroke volume is somewhere around 70 milliliters. Stroke volume is going to be influenced by a variety of things, including venous return, inotropic agents, and afterload. Venous return, this is the volume of blood that is returned to the heart. It's directly related to stroke volume. So the higher the venous return, the greater the stroke volume. This is going to determine the amount of ventricular blood prior to contraction. So venous return determines the end diastolic volume. The end diastolic volume is going to determine preload. What preload is the pressure that stretches the heart wall right before it contracts. Okay, so there's this thing called the Frank-Starling law. In essence, what the Frank-Starling law says that as end diastolic volume increases, the greater stretch of the heart wall is going to result in optimal overlap of thick and thin filaments. What does that mean? Well, that means basically when the heart is empty, the thick and thin filaments are not optimally overlapped. And as that heart fills up with blood, the more stretch put on the heart wall up to a point, the better the overlap of those thick and thin filaments becomes. And so the stronger the contraction can be. So when you increase venous return, when you increase preload, you stretch the heart wall a little bit. And this is going to allow those thick and thin filaments to optimally overlap, which is going to cause the heart to contract more forcefully when it's filled with more blood. And so this increases stroke volume in response to receiving more blood. Venous return may be increased by increased venous pressure or increased time to fill. Venous pressure increases during exercise. Okay, so this is going to happen as those muscles squeeze the blood through the veins and increase venous return. Time to fill increases with a slower heart rate. So in high caliber athletes, for example, who have strong hearts, they have slower heart rates, and this gives their hearts more time to fill. Venous return is going to decrease with low blood volume. So for example, if you're hemorrhaging and you're losing blood, the amount of blood returning to your heart is going to decrease. Also, high heart rate is going to decrease venous return. Okay, and that should make sense because if your heart is beating too fast, the ventricles aren't getting enough time to fill. And remember, we said venous return may be increased by increasing venous pressure or increasing that time to fill. Decreased venous return is going to result in a smaller end diastolic volume and therefore less preload. Less preload is going to result in a smaller stroke volume because of that Frank-Starling law. Balanced ventricular output is due largely to Frank-Starling law. As one side receives an increased blood volume, it's going to contract more forcefully. That is ultimately going to lead to greater fill and more forceful contraction on the other side of the heart. All right, other variables that influence stroke volume. Inotropic agents. Inotropic agents change the stroke volume by altering the contractility, or the force of contraction of the heart. This is generally going to be due to changes in calcium availability inside the cell. And calcium levels, remember, are going to directly relate to the number of cross bridges that can be formed. So positive inotropic agents are going to increase available calcium. That's going to increase the number of cross bridges that can be formed and increase contractility. Epinephrine and norepinephrine work via beta-1 adrenergic receptors to increase calcium. Remember, thyroid hormone works by increasing the number of those beta-1 adrenergic receptors. And then some drugs, such as epinephrine itself, but also digitalis, boost cardiac output by increasing contractility. Negative inotropic agents decrease the available calcium and thus lower contractility. Negative inotropic agents could be things like imbalances such as increased potassium or hydrogen ions, and certain drugs such as calcium channel blockers. All right, and finally, in variables that influence stroke volume, we have afterload. What is afterload? Afterload is going to be the resistance in the arteries. The resistance the arteries have to ejection of that blood by the ventricles. In other words, this is the pressure that must be exceeded before the blood can be ejected from the heart. Any condition that increases resistance to ejection is going to increase afterload. So, examples here would be aortic valve stenosis. If you have stenosis of that aortic valve, that means it's harder to get the blood to push through it. So that's an increase in afterload. Increase in systemic blood pressure. If you're hypertensive, if your blood pressure is 200 over 110, your heart has to pump higher than 200 in order to eject that blood out of the heart. Contrast this to someone with a normal blood pressure of, say, 120 over 80. The heart only has to pump to a pressure of 120 to get it past those semilunar valves. Okay, so hypertension increases afterload. All right, here it is for you laid out in a diagram, the variables that influence stroke volume. So you've got end diastolic volume or preload. You have inotropic agents. Remember, these guys act to increase or decrease contractility of the heart. And then you have afterload. That's the resistance the arteries have to receiving that blood from the heart. All right, I've left these charts in your PowerPoint for you guys to review. Just make sure that you can go through each one of these steps and that they make sense to you. Okay, as long as these make sense to you and how each one of these steps leads to the next, leads to the next, leads to the change in stroke volume, you're on the right track. Okay, and finally, variables that influence cardiac output. Remember, cardiac output is only going to vary with heart rate and stroke volume, and it varies directly. So an increase in heart rate is generally going to result in an increase in cardiac output. An increase in stroke volume is going to result in an increase in cardiac output. Heart rate is going to be controlled by chronotropic agents. That's going to include the sympathetic and the parasympathetic nervous systems. Stroke volume is going to depend on venous return, right, in diastolic volume. Inotropic agents, remember these guys influence contractility, and afterload. An increase in afterload is going to decrease stroke volume. All right, that brings us to bradycardia and tachycardia. Bradycardia is a low resting heart rate, below 60 beats per minute. Now remember, if your patient is an athlete, this might be a normal physiological adaptation in their body. However, for the average adult, a heart rate below 60 beats per minute is typically abnormal. Can be caused by certain health ailments such as hypothyroidism and some types of electrolyte imbalances. Contrast that to tachycardia. This is a persistently high resting heart rate, a heart rate of over 100 beats per minute. Tachycardia can be caused by a lot of different things: fever, hyperthyroidism, anxiety, even congestive heart failure. Congestive heart failure, that should make sense, because what's happening is, remember, the heart is not able to pump enough blood forward. And so what you're getting is you're getting a decrease in stroke volume. So to maintain cardiac output, what do you need to do? You need to increase your heart rate. All right, now let's end this lecture with a discussion, an overview of the development of the heart. So development of the heart is going to begin in the 3rd week of gestation with the formation of 2 heart tubes. And these heart tubes form from the mesoderm. So you might know this already, but in a developing embryo, as it develops, it kind of folds back onto itself and it forms 3 layers. These are called the 3 primary germ layers. The outermost layer is the ectoderm, the inner layer is the mesoderm, and the innermost layer is the endoderm. And each one of these layers is going to give rise to different structures in the body. Now, this primitive heart begins to beat by the 22nd day. In the 4th week, it bends and folds back on itself, and it develops these different expansions. So there's the sinus venosus, the primitive atrium, the primitive ventricle, and the bulbus cordus. Okay, this is a developing embryo in the 3rd week of gestation. Here they've taken different slices. You can see this is slice B, this is slice C, so let's look at slice B here. You can see the 3 germ layers very well. This layer here is the ectoderm. This middle layer here is the mesoderm. This is where the heart is going to come from. And then the innermost layer is the endoderm. All right, so what happens to those expansions? Well, the sinus venosus and the primitive atrium are going to form parts of the left and right atria. The primitive ventricle is going to form most of the left ventricle, and then the bulbus cordus gets further subdivided. It becomes a trabeculated part of the right ventricle. It forms the conus cordus, which forms the outflow tracts for the ventricles. And then it also, part of it becomes the truncus arteriosus. And the truncus arteriosus is what eventually gives way to the aorta and the pulmonary trunk. Here are those pair of heart tubes. They're beginning to fuse here around about 21 days. Here you can see about the 22nd day, you can see the expansions beginning. So you've got the bulbus cordus, the primitive ventricle, the primitive atrium, the sinus venosus. Here it is continuing to fold down on itself, and those expansions continuing to differentiate. And so now we have the truncus arteriosus, the conus cordus, and the trabeculated part of the right ventricle. This all makes up the bulbus cordus. Here's the primitive ventricle, here's the primitive atrium, and again the sinus venosus. Now in weeks 5 to 8, that single heart is going to get partitioned into 4 chambers, and the great vessels are going to form. The common atrium gets subdivided into the left and right atrium, and it's going to be divided by an interatrial septum. There's 2 parts to this interatrial septum. There's the septum primum, or the first septum, and the septum secundum, or the second septum. There is an opening in the septum secundum. It's called the foramen ovale. In the fetal heart, the foramen ovale allows blood to be shunted from the right atrium to the left atrium, bypassing the pulmonary circuit because the lungs are not functioning yet. Okay, here's what that looks like. So here we have the septum primum and the septum secundum here, and here's the foramen ovale. And what happens is blood is shunted from right to left through the foramen ovale into the left atrium during fetal development. All right, how does that foramen ovale close? Well, remember, when you're a fetus, your lungs are not functional, and so there's a high resistance in the pulmonary circuit, and that's going to cause blood to go from the right atrium to the right, from the right ventricle back to the right atrium, and then from the right atrium over to the left atrium, because the pressure in the left atrium is lower than the pressure in the right atrium. Okay, so fetal heart, the pressures on the left side are actually lower than the pressures on the right side. Now, when you're born and you take your first breath and your lungs become functional, that pulmonary trunk opens up, gives way, lets blood through, and so the pressures change in your heart. So after birth, the pressure on the right side of your heart is lower than the pressure on the left side of your heart. So as blood fills up in this left atrium when you're a baby, when you're born, it's going to push this septum primum against the septum secundum, and that's going to cause these guys to fuse together and close that foramen ovale. And that's how the foramen ovale closes and becomes the fossa ovalis. Remember, the fossa ovalis is the remnant of that foramen ovale that we can see in the interatrial septum. All right, here's a heart. They've kind of cut away part of the right atrium. We're looking into sort of the middle portion of the heart. This is the interatrial septum. This would be where the interventricular septum is. You can see here in the right atrium the fossa ovalis. Okay, and then you have an interventricular septum. This is going to partition the left and the right ventricles, and it grows superiorly just from the floor of the ventricles themselves. The AV valves, the papillary muscles, and the chordae tendineae are going to form from portions of the ventricular walls. Okay, let's talk a little bit about congenital heart defects. So there's a few we'll talk about. Let's start with atrial septal defect. This is when the postnatal heart still has that foramen ovale open. We call that a PFO, patent foramen ovale. So there's that opening between the left and the right atria. And what happens is blood from the left atrium is going to be shunted to the right atrium, right? Because remember, after you're born, the left side of the heart now has higher pressure than the right side of the heart. So blood is going to move from the left side to the right side. This can lead to stretching of that right side of the heart and enlargement of it. Then you could have a ventricular septal defect. This happens when the interventricular septum is incompletely formed, and again, this is going to result in blood being shunted from the left side to the right side of the heart. Then there's this condition called tetralogy of Fallot. What happens here is the aorticopulmonary septum, that is the truncus arteriosus, which you may remember back here, forms the ascending aorta and the pulmonary trunk. Well, the truncus arteriosus develops a septum in it, a spiral septum that divides the aorta from the pulmonary trunk. What happens is if that septum divides it unevenly, you can get tetralogy of Fallot. This is going to result in a narrow pulmonary trunk and an aorta overlapping both ventricles. With this, you also see ventricular septal defect and an enlargement of the right ventricle. So there's four things going on with tetralogy of Fallot. That's where tetra, meaning four, comes from. All right, so on the left here, we have a schematic of a normal heart, and on the right, one of a patient with tetralogy of Fallot. So right off the bat, you can see there's a ventricular septal defect here. This ventricular septum should extend all the way up here. It doesn't. And then you can also notice that there's right ventricular hypertrophy. Why is the right ventricle hypertrophied? Well, there's a stenosis of the pulmonary valve here. So it's harder to get the blood out. This is an increase in afterload. Okay, so that's going to increase right ventricular pressures. The increase in right ventricular pressures is going to cause this blood from the right ventricle to go to the left ventricle. So you're going to get mixing of deoxygenated and oxygenated blood. And to make matters worse, you have an overriding aorta. So this the outlet tract for the aorta kind of comes right down here over this ventricular septal defect. So the aorta is also receiving some deoxygenated blood from the right ventricle, as well as the deoxygenated blood that is moved into the left ventricle. So patients with tetralogy of Fallot, children with tetralogy of Fallot, the hallmark sign of it is going to be cyanosis, especially during crying or feeding or anything that increases activity in the child. This is repaired typically through one surgical repair nowadays. They can repair all of these defects.